Welcome to the first episode of Shrink Wrapped Faith, and I'm your host, Paul Donato. I am a psychotherapist. I have about 40 years experience in both inpatient and outpatient settings. And the focus of this podcast is really to help people connect with mental health issues as they relate to faith. In other words, we'll talk about mental health principally, and we'll talk about the place of faith in both the cause and resolution of mental health issues. My first guest today is Dr. Patricia Vance. She is a psychologist with many, many years of experience. And Dr. Vance, how many years experience do you have?
30 plus.
30 plus. So today's episode is specifically related to finding a therapist. And the data says that many people who are in the religious community of one variety or another start seeking help by inquiring of their pastor, minister, priest, rabbi, etc. The consequence of this is both positive and negative. And I'd like for you to explore a little bit about the positive and what should people do when they're in a mental health circumstance. Let's just say they're having marital difficulties. What should they do in the process of finding a therapist? So let's start with my first question, and that is, what is the promise of going to your faith leader first?
I wish there was a straightforward answer I could give regarding that. In many cases, it's a very positive way to begin, and in some other cases, it won't be positive at all. I think it depends on what the problem is that is bringing you to seek treatment of some sort, and the kind of relationship that you have with your faith leader, be he a priest or a rabbi or a minister or whatever you may call him or her, and what kind of relationship your family has with this person. There are a couple of things. One is if you're very active in your church and you're involved in a variety of different roles, it may be that there are some things you need to talk about that you don't particularly want to talk about with somebody that you know in a more personal way. And although I can guarantee you your faith leaders are sworn by confidentiality just as mental health therapists are, and your secrets are likely very safe with this person, your secrets might be really safe with your best friend too, and you just don't want to go there with a close friend. You want somebody who is more outside of your life, more anonymous, and who can really have a more objective look at the kind of things that you're talking about. The positive of doing it is that if you trust this faith leader, you already have a trusting relationship. If the issue that you are having has at its core issues to do with your own faith, then the faith leader might absolutely be the person that you want to start with. So like I said, it's very difficult to say, yes, you should definitely start with your priest, or no, you really shouldn't start with your priest. But it's something that I think is good to consider if you are in the pews, but you might consider it and decide, no, you want to look elsewhere.
So what kind of problems, if any, should you bring to a faith leader?
Well, certainly issues of faith, and perhaps issues of death and dying. Certainly if you're confronting a terminal illness, or you've got a family member who is, and you're struggling with anticipatory grief, or you're wondering, where was God when you needed him? A faith leader would be a good place to go. Most issues aren't quite that cut and dried. There are people that have illnesses, but those illnesses connect to all kinds of other things, and they need absolutely a faith leader, but they may also need a secular therapist to help tease out everything.
Okay, so you're talking primarily about situational problems, grief, approaching illnesses, maybe marital strain. Is this the range for a priest or a minister's skill level? Or where do you think they end in terms of their ability to go further?
I think it's going to be different for probably just about every person, depending on their individual training and the experiences they've had during the time that they have been a faith leader. I'm just thinking that if you're having racing thoughts and you can't sleep at night and the depression when it hits you is so severe you can't get out of bed, probably you need a secular therapist and maybe even medication. That's not to say a faith leader wouldn't be a good adjunct to that treatment, but they shouldn't be carrying the sole burden. That's going to be more than they're up to. But I'll tell you, I have many clients, many over the years, where after they're finished consulting their priest, the priest will turn to them and say, "And you are still talking to Dr. Vance, right?" And the client says yes. And when she finishes talking to me, I'll say, "And you are still talking to Father so-and-so, right?" And she'll say yes. And we're giving each other our regards through this client because we know she needs us both. She needs me to help her with some very practical applications to anxiety and depression. And she needs him to help her deal with the burden of her grieving in many different situations. And we work together.
Yeah, I understand what you're saying. So it sounds like for our listening and viewing audience, we might want to break out the various types of problems that would definitely be within the purview of a faith leader. And those problems that would not be really a best place to start with certain kinds of presentations. So I think many of the people viewing and listening to us may not really understand the distinction between situational circumstances and disorders.
Right.
Or problems that people don't like this terminology that involve mental disease.
Right. Or problems that are just more chronic.
Yes. Yes. Yeah. So why don't you talk a little bit about what is the general breakdown? Because there's a lot of psych speak out there.
Yes.
You and I both hear in our practice about, oh, my boyfriend's got bipolar, my mother is psychotic, my sister has OCD, and we hear these terms thrown around.
Yeah.
So why don't you help our audience sort out between situational circumstances that are often time limited and other kinds of circumstances that have both great duration and significant intensity?
Okay. Well, I would start by saying if the problems that you're having, whatever they may be, have lasted more than a handful of weeks, stretching into months, and if the problems that you're having are impacting you both in your personal life, your relationships, but also your work life, your parenting life, to the point where you're not functioning in any of those domains, or you're not functioning well in any of those domains, you need professional help. If you have a faith leader who tells you you just need to pray harder, you probably need professional help. If you're confronted with the kind of problems that are frightening to you, like you haven't been able to sleep for months, you're having nightmares that make you feel like you're crazy, if you're having anxiety to the point where you can't do something that you should normally be able to do, like, drive, talk to more than one person at a time. I mean, even socially. If you're struggling to function, you need professional help.
So, as I mentioned to you earlier, what you're making a distinction between is more temporary versus more long-term problems and the nature of its intensity. I was always educated to the idea that the way to really assess a problem is by its duration and intensity. How much of the problem is pulling you away from your functioning, whether it's your job functioning, your functioning as a mother or father, or any other role. but then it's something that's lasting for weeks, months on end.
Yes.
In your experience, does the problem often have a kind of a wave look to it? In other words, peaks and valleys. It looks like.
Yes. It gets worse and then it gets better, and then it gets worse and then it gets better, and it's a real an ebb and flow.
Right.
But if it gets worse and then it gets better, then it gets worse and then it gets better, but it never goes away, you probably need to think about professional help.
Yeah. So this is not to dismiss the faith leader.
Not at all.
But,
Not at all.
But what I hear you saying is that at a certain point, you're going to have to be a good consumer of your health care.
Yes.
Based on your understanding, and not that from Dr. Google.
Yes.
That the symptoms are pervasive and they're not going away. And although you might get adjunctive help with prayer, with meditation, with other kinds of recommendations that your faith leader might have.
All of which could be very helpful.
Yes.
But if they're not solving the problem, you need help.
So that's when you need to move on.
Yeah.
Okay. So let's talk about some of the problems that most people might in their life confront, generally speaking. Now, the literature says that anxiety is the greatest presentation in number and frequency in a clinical setting. Would that fit with your experience?
Because there are so many different kinds of anxiety, so many different ways that it presents. When you add them all together, absolutely, they take the cake. Yep.
So let's describe more in detail for our viewers. What do you mean by different types of anxieties?
Well, there are people who worry all the time about everything. And if one problem goes away, they'll find something else to worry about. It's a constant stream of worry. You know, they're worried about money until they finish writing all the checks and paying all the bills and see they still have plenty left over. So now they're worried about the car breaking down, and then the car doesn't break down. So then they shift and they start worrying about their kids' performance in school, and their kids are getting straight A's. And so now they worry about whether or not their husband's cheating on them. There's always the next thing to worry about, and the constant worry just never goes away.
So some people might call that generalized anxiety disorder. Or
that's exactly what they would call it.
I think another thing we should do to help people, because you and I are comfortable with this shorthand, is to explain to people the difference between a trait and a disorder.
Oh,
so
good.
That they understand.
Yes.
When they look at a diagnostic that they pull up on Google or some other setting, right? And they see these lists of behaviors,
symptoms. They see a list of symptoms. Yes,
and then they add them all up, and they say, "Oh my, I have that."
Yes,
or he has that.
Because in fact, everybody worries about something some of the time. I mean, it's like depression. One key symptom of depression is sadness, but everybody gets sad from time to time.
Right.
So what's different about clinical depression compared to everybody? Just every now and again you get sad, and I think it's the intensity and the duration, and there are a lot of different symptoms of depression. I think if we counted them all up, there's like 9. And for somebody who has clinical depression, those symptoms all are there to a certain extent, most of the time, most days. And so it's not that you got sad because you had a fight with your best friend. That would make you sad. But is the sadness continuing beyond that? And in addition to that, does it make you feel badly about yourself? Are you figuring, well, if your best friend's mad at you, then obviously you're a horrible friend. Nobody's going to like you. There's nothing good about you. And you take these things out to extremes. And that's when it becomes clinical.
Yeah. Okay. So what people have to keep in mind is that you can have a trait. Personally, I have traits of OCD. I mean, I don't have OCD. OCD is very consuming.
Yes.
Right.
You do not have OCD.
Right. But I can be very careful about things and more or less making lists and trying to fulfill those lists, etc. But those are traits. They're not.
Yes.
It's not consuming.
Yeah. And your point is, this is a disease compared to somebody who likes to have things just so, but they still function in the world. They get along fine.
Right.
It doesn't really get in their way. In fact, it might actually help them.
Right.
And so they have traits. Another example would be somebody who has a personality disorder compared to somebody who just has traits of a personality disorder.
Yeah, I think we should save that for another podcast. The personality.
I guess that is another podcast.
Right.
Yeah, you're right.
But although people throw around these terms,
yes, they do.
You know,
yes,
my boyfriend is borderline, or my girlfriend is borderline.
Yes, exactly.
Okay, but as you know, and we could remind the audience that
every single one of the descriptors of these personality disorders, everybody has, just not very often and to a minimal degree. Yeah, unless you're a 13-year-old girl, and then you do have them all. But yeah, you're going to outgrow it.
Yeah, you're going to have them. And here's the other thing. I have found that clinically, you can't even really make a true diagnostic statement until you've known someone for probably 6 months or longer to see the pattern in the behavior.
In terms of personality disorders, absolutely.
Yes.
Absolutely.
That's why I'm saying I think it's for another session.
Yeah, I would agree.
Very
I would
involved
agree.
area. All right, so going back to mental health and finding a therapist, because that's the main focus of this.
Okay.
I started with the faith leader. Now let's go on to, you've been with the faith leader. He or she recommends that maybe you should get some help, or you decide that this is not really getting to the bottom of it, or you decide, you know what, I'll stay with this person because they offer a good perspective, particularly related to relationship issues. However, I need to go on. I need to move on. Now, there are so many opportunities to get mental health care, but in the same breath, and I'd like to get your opinion on this, the system is very convoluted.
It is.
And if you're not familiar with it, you could wind up in a circumstance where you're not getting the best help you can get, or you don't get any help at all.
Or you don't get any help at all.
Right.
Well, my advice would be, to begin with, are you independently wealthy, or do you want to use your health insurance? And I'm being a little bit glib, but if you choose to not use your health insurance, it may get prohibitively expensive for most people, just because this is not something that is dealt with in 2 or 3 sessions, typically. Mental health treatment becomes a relationship, and it takes time to build these relationships. Some of the problems that people want to deal with are deeply intracted after potentially years of problems building, and you don't undo 15 years of problems with 3 sessions. You know, it takes some digging. So if you choose to use your health insurance, I would suggest, first of all, consult with your insurer and find somebody who is a preferred provider for your health insurance. Most insurance companies have an online source that you can go to and find preferred providers, not just somebody who accepts your health insurance, but somebody who is a preferred provider, because somebody who accepts your health insurance may not be a preferred provider and you wind up paying more. And so that's something to take into account.
How would you select someone? I mean, I have some very clear ideas.
Yes.
In my own treatment selection. I had some significant criteria. What criteria would you offer for people to check the list?
First, let me suggest that the person's gender, ethnicity, and age really have nothing to do with whether or not they're going to be a good fit. But these are still important variables for some people. And so if you decide it's really important to you that you be seen by only a male or only a female, or you want somebody who's Black, or you want somebody who's Native American or Asian or white, like I said, it shouldn't make any difference in the level of treatment that you get, but it might make a difference to you, the client, in the comfort level you have with the individual, at least in the beginning. So I'll just put that right out there. After that, some people really, they're interested in location. Some people are willing to drive for 30 minutes. Other people want somebody that's, around the corner. So see what's doable for you. If you have to take the bus to get there, that's different from you've got a car. Some people want somebody who will do telemedicine. Other people want to see somebody face to face. These are all things that you're going to have to explore as you look. I think the most important thing is the fit. And the fit is something that you will only know by sitting down with somebody and talking to them for a session or two. And so I would get everything else to be okay. You really want a female, or you really want somebody who is young, or maybe you're shopping for your teenager. You think they would do better with a man, or you think they would do better with somebody who is under the age of 30, whatever. Find a person that meets that criteria, that is within a reasonable drive of where you would be driving from, and call and make an appointment. Are they taking new clients is an important variable. And most people are going to get the answer, yes, they're taking new clients, but we have a waiting list. Mm-hmm. So get yourself on the waiting list. And maybe call a couple of different people and get yourself on the waiting list and see how long it takes to be able to finally get in with somebody. There are some therapists, like myself, who aren't taking new patients right now only because I'm old, folks. I'm old and my caseload is long. So I want to do well with the people that I've got, but I don't want to overextend myself. Other people are young and eager, and they'll take on a whole lot of people and do just fine because they have the energy to do that. So get yourself onto some waiting lists and then shop. Yeah. And the first person that calls you, make an appointment with them, have a couple of sessions. If it feels comfortable, great. Cancel the other people. If it doesn't feel so great, wait until maybe this is not a fit. Maybe one of the other people will be a better fit. But anybody that you meet with, give it at least 3 sessions, I would say, unless right away you want to run screaming out of the room. You don't like this at all. But otherwise, give it at least 3 sessions to see if there is a gel. Is there a connection? Can you feel is it good? Okay. And again, the single best predictor of the success of therapy is the goodness of fit between the client and the therapist. And that's irrespective of training or background or anything else. So look for the fit. That's what I would say.
Let me use this expression you just offered, training and background. Now, what is your take on that? I mean, there are many, many people who are now in the universe of therapy.
Yes.
Offering their services.
Yes.
And there's a huge range of skills and training.
Mm-hmm.
For our listeners, you want to sort that out. You want to help people understand what they might see and what to avoid.
Okay.
I mean, let's talk about this the way we would choose someone. Let's give them inside information about if we had a family member or either one of us as practitioners, how we would choose someone to get help from.
Right. Well, we can start with psychiatry, I guess. Psychiatrists are medical doctors, and they specialized in medical doctoring of the brain, of the mental health condition. Many of them do not do talk therapy any longer. They are strictly writers of prescriptions for medication, which is fine. There are others who do talk therapy, and they bill for talk therapy and they provide talk therapy, and that's fine too. But that's one group of provider. They're the least likely to be providing services that are talk therapy, but there are some of them out there. Psychologist is a person that has a PhD in psychology, and in this sense, they get to be doctor, but it's an academic degree, not a medical degree. Psychologists are trained to be therapists and other things too. Psychologists get trained in all of the psychological testing. You can have a neuropsychologist who does neurological psychological testing. They have psychologists who work in the public schools, school psychologists. There are a variety of different kinds of psychologists. But if they have a license, then they're able to provide talk therapy to people. They have a lot of training that is training above and beyond what they really need to be able to do therapy, but it's there and it can be helpful in its own way. And then there are licensed professional counselors who have a much shortened training period. It's typically 2 years of classes plus a year of internship. It might be a little bit longer depending on the particular program they go to. They don't get all of the testing training, but they get much more concentrated training in therapy per se. And then there's the licensed clinical social workers who also get trained in a dual track where they are trained to do mental health training and they're also trained to do social work in other non-mental health kinds of ways, like to do social work in hospitals or agencies. I have known some very well-trained psychologists that I would send a family member to in a heartbeat, and I've known some other psychologists that I wouldn't go to and I wouldn't send a family member to. And the same thing is true of professional counselors, and the same thing is true of licensed social workers. Mm-hmm. There are some that are very well trained and are wonderful people and would be great therapists, and others that are maybe not quite so well trained or might be very well trained, but just their personality is such that they don't do such a good job as a social worker. So I can't I've given you the breakdown by training, but there are some professional counselors I think would be wonderful therapists, just like there are some social workers that I think are wonderful therapists, and others that just really aren't good. It all comes down to the fit. It's the fit.
Can you explain to our audience what we mean by differential diagnosis and why it takes time and you need to find a well-trained person? Could you explain that to them?
Yes. Somebody goes in to see their therapist, brand new client, and the person is convinced that he or she has bipolar disorder. And the therapist says, well, gee, okay, let's talk about the symptoms that you're having. And sure enough, the person does meet criteria for depression, kind of a mild depression, but it's still depression. But they describe these mood swings. And trying to figure out exactly what these mood swings are or what they mean. And the client says, they really bother me. Sometimes they keep me up at night. It really worries me. I seem to be really angry a lot. And the hasty person, often the hasty psychiatrist, I'm sorry to say, will say, yep, that sounds like bipolar to me. And they will prescribe medication. And in fact, I have 3 different cases where this has happened. 3. And as I've gotten to know the person, I certainly have seen the depression. Absolutely. And then in some cases, I see the mood swing, if you will. I see an anger outburst that is just an explosion. And it goes off, and then it's right back down to where it used to be. I mean, there's no duration to it at all. And the person had a mood swing and that they seemed really happy for a moment, but they seemed really, really happy and got into kind of a laughing jag for a second. And then within a few minutes, it shut back down again. And in another case, it was a symptom of just being really, really busy for a period of time. And the busyness and being caught up in the busyness. But again, it shut down again very, very quickly. And in all 3 of these cases, all 3 women had a pretty significant depression that was absolutely helped with medication. But the bipolar wasn't bipolar at all. They actually had post-traumatic stress disorder, yes. All 3 of them. And we were seeing anger outbursts that you can see in PTSD. They were having flashbacks that you can see in PTSD. and they were having, and different kinds of flashbacks that you can see in PTSD. And the doctor kind of shut it all down a little bit with a prescription for a mood stabilizer, which didn't really solve the problem. Might have helped a little bit in the beginning, but the issue was this is not bipolar. They didn't take the time they needed. And in fact, in all three cases with me, it took months before we finally figured out what was going on. Months.
So let me tease out what you're saying relative to differential diagnosis. I think what you said earlier about haste, you don't want someone as a consumer of this service who's going to shoot from the hip. They're talking to you for 10 minutes and they say, oh, you're this. I'm also hearing you say that there are many other problems that could look like something.
Yes.
Okay, so this person's behavior could fit into multiple categories during the evaluative process. They could be depressed. They could be dealing with stress.
A stressful event, yes.
Okay. And that, would you agree that differential diagnosis is really the consumer client should be asking the person, why did you choose X? Why did you say I was depressed versus some other thing? Right? And that's the real skill, isn't it? It's not just picking up a book, the DSM-5, memorizing, right?
Let me give another example. There is a symptom that we describe as inability to concentrate. And that symptom is found for people with anxiety, it's found for people with depression, and it's found for people with ADHD, attention deficit hyperactivity disorder.
Right.
And so if somebody comes in and it's like, I can't concentrate, I must have ADHD. And that's happened to me, especially among young clients. And I mean young, 17, 18, 19 years old. They're convinced they have ADHD. And maybe they do, but if you continue teasing out all of the other possibilities and figuring out what else could be going on, it may be, in fact, they do not have ADHD. They have anxiety. And the anxiety is what's interfering so much with their ability to complete assignments and pay attention and focus and not go into daydreaming. Or they could have PTSD, where we have a lot of daydreaming and not. So differential diagnosis takes time, and it can be confusing. And particularly young people who are really into Google and Dr. Google, they will latch on to something that makes sense to them without really understanding all of the different ramifications.
And that's the issue. And that's what the training is all about. And experience.
Yes.
That people will, like any phenomenon. I mean, you could go to your primary doctor with a cough. That cough could be anything from a slight cold, seasonal virus, to a lung cancer.
To seasonal allergies, yes.
Right. It could be the whole range. And so it's sorting out. Now, what do you think it is? It's almost going to sound a little elitist, but this idea about experience and a person posing as a therapist, but they've been in practice for maybe 2-3 years.
They're not just posing as a therapist. They are a therapist, but they're still learning. Well, shoot, I'm still learning. I hope you're still learning,
I understand
too,
that.
but...
What I'm trying to talk about is that there's generally a consensus in this field, and you correct me if you think I'm wrong, that without 5 years experience, actually seeing people, but beyond schooling and beyond licensing,
you're still a neophyte.
You're a neophyte.
Yeah,
that's
absolutely.
where I'm going.
Absolutely.
Maybe it's not elitist, but it's more of a touchstone for people who are looking for a therapist. In other words, if I was looking for a therapist, I would never choose somebody with 2-3 years experience.
No, I understand, and it could be a touchstone, but there's school teachers will tell you that until you have 5 years of experience teaching school, you're still a neophyte. So it's like any other practice that you do, whether you're practicing as a dentist or a therapist or a school teacher or a pharmacologist. The more experience you have, likely, the better you will be at what you're doing. But it comes back to the goodness of fit.
Yes.
It's still a relationship. And if a client comes in to see me and they just feel like I'm too old, I can't possibly relate to their problems, and yet a student I'm mentoring currently who's like 50 years younger than I am, they're happy to see her because even though she only has 6 months experience, she can relate. Then they're going to do better with a student.
Okay, so touched upon a couple of issues here. We've touched upon training. Is all training the same? I mean,
No,
I know
no,
you talked about the categories, but
no,
let's
no.
just take psychology, for example. Is someone who's licensed as a psychologist, is that training universal in terms of its
No,
content?
no. You can have two people who graduated at the same time from the same program, from the same school with the same degree, and one will be wonderful and the other one will suck.
Right. But I'm talking about in terms of training exposure. I think you touched on that earlier when you broke down the different categories.
I mean, most people have at least a full academic year of in-person, face-to-face training, performing therapy. Some people have more, some people have less. And again, it kind of depends on the training program they went through.
Yeah. Well, I think one thing is that any person that someone seeks, they must seek someone who is licensed by the state.
Absolutely.
That licensure is really the cut. It would be like seeking an attorney who doesn't have
who never passed the bar.
The bar, right?
Yeah,
or
right.
A surgeon who is not board certified in surgery. Right?
Exactly.
So licensure is a key. What do you think of these people who call themselves life coaches? Is that someone that should be involved in this line of work?
No, I don't think so.
Okay.
I mean, not that there aren't some wonderful people out there probably who call themselves life coaches. And if you're looking to turn to somebody and just, your best friend is on vacation and you want a life coach, okay, I guess, except you're paying them out of pocket because they can't bill insurance. And there's no licensing, at least in the state of Maryland at this point, for a life coach. And the training is nominal. And so why? Why waste your time? Why waste your money?
Now, one of the reasons that people sometimes back away from therapy is if the therapy session concludes with the therapist saying, at this juncture, you might really do well with medication to assist you. Let's talk a little bit. Let me get your opinion about how one should think about medication in relationship to their therapeutic engagement.
Okay.
How would a client think about that?
Okay, well, first I will say many years ago, I had a client tell me that she felt guilty about coming to therapy because her minister told her she should just be praying harder. And my response to her was, why do you think God made psychotherapists? I would say in the same way, why do you think God made pharmacologists? I mean, why do you think God invented medication? It's a tool that is there to help. There are some people who don't need it, and there are some people who desperately do need it. And in almost every case where a therapist is recommending it, it's probably worth a try. Now, are there some natural things that you can do rather than going to medication? Sure. You can follow a careful diet. You can make sure that you're eliminating junk from your diet and heavily processed foods and that kind of thing. You can do exercise. We already know that one of the best treatments for anxiety is exercise, and it really helps with depression too. Might help regulate your sleep. With a good night's sleep for a few weeks in a row, you might be feeling enough better that you don't need medicine. But there are some people who absolutely do need medicine, and most of the medicine that is available is healthy and safe with minimal side effects. and under the care of a good physician, doesn't have to be a psychiatrist in the beginning, could be your primary care doctor. It's worth a try. I think it's good to try therapy without medication in the beginning. It's been rare for me after one session to say to the person, here's the name of a psychiatrist that they think you need to go right away. It has happened, but it's not typical. But if medication is necessary, I think within at least a handful of weeks is probably a pretty good idea.
Yeah. I like your use of the word tool, that it's not some sort of statement that you're really sick.
Right.
Or that you're somehow beyond the pale of health.
Right.
That you're.
It's a tool.
It's
also
tool.
not a panacea. I mean,
right.
It's not going to solve the problems.
Right.
Hopefully, what it will do is calm down the system enough that you can bring to bear the energy, you, the client, can bring to bear the energy that you need to work on the problem to actually fix it.
What do people do that often they think is helping, but actually makes the problem worse? What do you say?
We would call self-medicating. They drink, or they smoke, or they eat gummies, and it's really a shame because it feels better in the moment, and then that moment passes, and they wake up, they still have all the same problems that they had, except now they've got a hangover. And those are folks that need to get themselves to AA as well as a mental health professional as quickly as they can. So they can have a partnership between their mental health professional, their medical doctor, and AA, and the people, the good folks in AA to help them get through this.
Yeah.
Because it is nothing but making things worse.
Right. Well, sometimes it's very difficult to treat the underlying problem. Let's just say that they're depressed, they're grieving the loss of someone. But then they turn to drinking.
Right.
And they think, well, I'll have this little wine and I'll have another glass and another glass. Now you have someone who is self-medicating and is unfortunately now building a habit that becomes a crutch, something that they're relying on, maybe to sleep.
Yes.
And next thing you know, now they come into therapy. And I think what you're saying is the first thing that a therapist has to do is help them get out of that problem.
Yes.
Of the alcohol use before they could drill down into the depression, into that grief. And they can
deal with the depression, the grief, early childhood abuse, whatever it is that was creating all of these problems. Yeah.
So, I agree with you. I think there's a very difficult circumstance there when people self-medicate. Not only is it a short-term remedy, but it has long-term negative consequences.
Yeah. And I didn't used to push AA for clients, and I still don't push it if they promise to stop drinking. But if they can't stop drinking with therapy, then by golly, they really need to get to AA. And I've seen AA really help people turn it around.
Yeah. Okay, well, I think this has been a good conversation about what therapy is, how to go about finding a therapist, why your faith leader can be a good start, but you have to also be conscious of what you need.
Right.
And that you can use both your faith leader and the therapist.
But sometimes people have problems that they don't want to discuss with their faith leader because they're embarrassed to have him or her know.
Right.
And so you want to go to somebody who's anonymous.
Yeah. And then you should not shy away from a suggestion of medication. See it as a tool.
Yes.
And not really a representation.
It's not the solution. It's a tool.
Okay. So we're going to wrap up now, and I'm going to invite you back again because we have many more topics to cover. And you're quite clear in your presentation about what are some of the things that people need to do to select a therapist.
I hope I haven't sounded too biased.
No, I didn't hear a bias. Of course, I'm biased anyway, but I mean, I didn't hear a bias. What I did hear was helping people really use all the resources that are available to them.
Yes.
But this is not about A versus B.
Great.
This is not either or. This is a look at the whole waterfront of opportunities here to help yourself.
And also, I think, remember, for people who really want a faith-based therapy, many therapists are willing to go there with you.
Yes. Yeah.
Many therapists.
Yeah.
I go there with several clients.
Well, that's been my training now. I've taken my mental health training, and I've started studying religion formally and with continuing education as well. In the event that people want to go there, there's a way to talk about that.
Exactly.
Without selling anything or
yes.
Trying to
It's
persuade.
not a conversion process.
Right,
exactly.
right.
Yeah.
Again, it's another way of thinking about the problem.
And helping people try to find their way.
Yes. Okay, so let us close out now. And I will invite you back, as I said, and
Thank you.
maybe clear the air of psych speak that is out there. We are in the therapeutic age.
Yes, we are.
Everybody uses this language. Thank you for listening to Shrink Wrapped Faith, and I hope you join me for our next episode.